Okay, good evening, good afternoon, ladies and gentlemen. This is, today is the second part of Professor Francois Dabis' lecture about AIDS. And last week it was really basic information about World AIDS, but maybe today's one is more detailed, more updated. And one thing I wanted to add, because myself I was surprised that today or yesterday he was invited. he received a call from Ministry of Foreign Affairs, maybe, French government. So French president, who is the name? Do you know? Someone who you don't know? Not Sarkozy.
No, not anymore, not anymore.
After Sarkozy, internship student who went to France. Do you know? Do you know the name of president? France. Mr. Hollande. Socialist, you know? He invited him to accompany to South Africa, because this is the first visit of French President Hollande to South Africa. So he was invited as advisor. So next week already. So he's such great person, very famous in the field of AIDS, especially in Africa. And as I told you last week, he's very, from the very early stage of AIDS epidemic in 1980s, he went already to Rwanda to start a serious cohort study for child AIDS. It was really impressive for me, because even for me, who was working at that time in Pasteur Institute as a researcher, as AIDS researcher, didn't think to do it. That means in 1980s, go to Rwanda to study AIDS in Africa. Because AIDS in Africa at that time, the beginning of AIDS epidemic, AIDS Africa was almost something abandoned. Nobody wanted to do it. Okay, that time he started already his work. Since then he continue. That's why he was invited as advisor of French president next week. Okay, so please listen carefully. Second part of his talk today.
Thank you, Naomi. Thank you. And between last lecture and the conference I gave, I was able to enjoy a little bit of Japan, thanks to the conveners here. So I'm very glad also to have discovered more of Japan. Okay, so last week what we did is we basically discussed, kind of the burden of disease, the burden of the problem as it is now, okay? What I will like to do with you now is discuss the rest, which is basically think about the history, how a health problem emerges, becomes a global problem, and basically all the mistakes we did in 30 years, because we did many mistakes, also many successes, okay? Because what I described for this particular health problem applies to many of the conditions that you are interested in general. So I will move directly to the second part. This is basically the same PowerPoint that I used last time. And I am somewhere here, okay? So I'm going to think now about the history of a global problem like this, how it started and how it reached the point that I described last week. Okay, you have to remember that this history is brief. It's 30 years, okay? 32 years, if you think about it. Think about all the health problems that we live with. Most of the health problems that we know, they have been present with us for centuries, okay? All the infectious diseases have been present for centuries and centuries. You can find textbooks or, even the general literature about diseases like measles, for instance, like smallpox, okay? This existed several hundred years ago, okay? Everybody knew about it. This particular disease, 32 years ago, nobody had ever heard, okay? So it's a brief history and also a very sort of condensated things that has happened. Okay, what I'm talking of June 1981, because this is exactly the time where almost at the same time in several places in the world, San Francisco, Los Angeles, but rapidly Paris, first people with a new disease were basically hospitalized and died briefly after that. And it was a completely new thing and a very bizarre disease because people were suffering of complete alteration of their immune system, okay? But they were extremely young, in their 20s, in their 30s, at an age where usually you are very strong, okay? So all of a sudden, the doctors discovered a new disease of the immune system in people that they would have never imagined to see patients of that age with these kind of conditions. And this emerged so abruptly and so in different places that at least in the United States of America, all these clinicians, these doctors, they contacted the central place where all the epidemiological information is collected. That's the U.S. Centers for Disease Control, U.S. CDC, based in Atlanta, where they say, listen, in San Francisco, in Los Angeles, we have these very strange patients. Do you know what's going on? Okay? And the CDC, basically what they did is they captured this information. They put that in a very simple summary document in their weekly report. And they shared it with the medical community. And what we discovered is that in a couple of weeks later, there were not only patients in San Francisco, in Los Angeles, but also in New York, in many other places, and rapidly also elsewhere. And the very first other cases that were reported at that time was in France and in Europe in general. So a disease that had never existed on the surface of the globe, it's a very bizarre thing that in a couple of months or year appeared at the surface of the globe in many spots at the same time, okay? And the information started to be collected to try to make some sense out of it, okay? Here we start 1981 to 1983 by doing basically what we call the epidemiology of this new disease. The epidemiologists, the medical epidemiologists, what they tried to do is characterize this new disease, characterize it, describe it. And once they had enough cases to describe it, what they do in a context like this, and that applies to many other health conditions, they try to understand why these people have the disease and why others who are almost similar do not have the disease. And it became very clear by 1982, I would say, that this disease was brand new, for sure, very severe, for sure, and that it was probably a transmissible disease. Okay, it was transmitted from one person to the other. That became very clear to all the reports that came from all over the world. What was supposed at that time is that there were two basic options in terms of transmission. Either the disease was transmitted because there was some mysterious, I would say, toxic agent, okay, or it was a new microbe, virus probably, that was appearing. Basically, these were the two concepts that were hypothesized in 1981, 1982. But by the end of 1982, it was almost ruled out, the toxic hypothesis, okay, because it didn't fit well with what we were seeing, and the patients looked like they were having an infectious disease, okay? That's very clear from almost the beginning. And what was almost clear at that time is that the virus was it was possibly a virus, but we didn't know, but probably an infectious agent, and that it was very likely to transmit by sexual intercourse. Okay. It was very clear from almost the beginning, 1981, 1982, that it was transmitted through homosexual intercourse, but it became almost clear at the same time that it was also transmitted by heterosexual intercourse from men to women or from women to men. And also around the same time, 1982, 1983, it became clear that blood products could be another route of transmission, either directly, because blood products seemed, I would say, to be contaminated, or that intravenous drug use was also a possible mode of acquisition of this new infectious agent. Okay? So what I want to tell you is that this is absolutely unique in the history of humankind, that a new disease, a new health problem emerged in many parts of the world at the same time, okay, was characterized in about 2 years, okay, that in 2 years we were almost sure that it was transmissible, that it was transmitted in several ways that I just described, but at that time we were not quite sure where the solution was, in other words, what the agent was. And this came obvious in June 1983, so almost a little bit more than 30 years ago, when a new virus was formally discovered. Okay, a new virus taken from the blood, or exactly from a lymph node of a patient in Paris, was just taken from the patient, brought to the Pasteur Institute, and a team of virologists ultimately discovered a new virus that they had never seen before in the lymph node of this patient. Okay. Well, you may have heard that at that time, American scientists made a similar discovery, and that for many, many years, the belief was that the virus was discovered exactly at the same time by French researchers and by US researchers. Why was this fight so important? Why was it important for American people to say that they had discovered the virus at the same time than French scientists? Do you have any idea why it's important to say, I am the first one to discover the virus? In the field you are going to work, once you do a scientific discovery, what are the possible implications? Patent, okay? Patent. You discover a new entity. Maybe this entity can be used later on by new scientists to develop technologies, okay? This technology will have a price, okay? And on this price, the patent will allow to the researchers or their institution to get a small percentage that could be potentially very important in terms of resources. So the Americans were very keen in saying, we discovered it at the same time. And the publication came in the same scientific journal on the very same day of June 1983. Okay. And the competition between the two sides of the Atlantic was extraordinarily strong on that. Okay. What is the final answer? Is this still true? And are all the patents divided by Americans and French? Do you know about this? No. What do you know? What has happened after that? Basically, what has happened after that is that the Americans were very, very pushy on this until the negotiation in around 1986, 1987 reached the consensus that, okay, we will share all the royalties, the patents on this. Okay? What has happened around 2006 or 7, I don't remember exactly the year, who was awarded the Nobel Prize for the discovery of the virus? You know the name of the scientists who were awarded the Nobel Prize for discovering the HIV virus? Okay, if you don't know the name, what is their citizenship? No, they are French. Okay, they are French. The French team, who was at the Pasteur Institute in June 1983, was awarded in 2006 or 7. I don't remember now exactly the year. Maybe Naomi remembers. It's about 7 years ago, 6 or 7 years ago. Yeah, 2007, I guess. The Nobel Prize of Medicine for their discovery of the HIV virus, which is the final confirmation that the virus was exactly discovered in France. And what the Americans did at that time, they just copied. They just, how would you say that? They looked, at the French scientists, bench, and they did the same. In fact, it's even worse. The sample that they used to discover the virus in the US was in fact a sample that they had stolen from the French lab. Not stolen in a formal way, but this is something that they were not, So with the Nobel Prize, it becomes, yes, absolutely clear that the discovery was made in France. Yes, please. Not leaked. There was a lot of tension around that time because the concern of this disease emerging, these groups were really working extremely hard with a lot of very good competition. And in competing, they were also exchanging a lot of information, a lot of material. But in the end, basically, had the French not done what they did, the Americans would not have been able to replicate the experiment. Okay? Okay, I'm not going to argue that they were poorer or better. What I'm arguing today is that it is clear that the discovery was made in Paris. Fine? Okay. I have summarized very rapidly this. I will go into more of the details, but I have put three more dates on the horizon of these 30 years, and I would just want to take you there very briefly. December 1997, Abidjan it's in Ivory Coast, so in West Africa. This was a big AIDS conference in Africa. At that time, the recognition that the epidemic was important on this continent was clear. But Naomi was there, if I remember what you said, yes. I was there too. And the president of my country, Jacques Chirac, at that time, was the first politician in the world to say that this was unacceptable, that treatments were not accessible to lower income countries, poor countries. Okay. This is first time that the politician takes the risk of saying, this is an enormous problem. We have treatments. and they are not there. We must do something. Okay? Very first time. But you know, Jacques Chirac is not a huge politician. And France is a small country. So I'm not sure it was really listened very carefully. But what happened in July 2000 was that in the next round of conferences, the World Conference on AIDS happened to be in Durban. Durban is in South Africa. Okay. And the president of South Africa at that time was a very important politician. Who was he? Nelson Mandela. And Nelson Mandela said exactly the same thing than Jacques Chirac, but at a much higher level, because he said, this is not acceptable for us, Africans, that we don't have treatments and that we cannot take care of our people. From then, it became almost impossible for the global community, okay, to just let things go. Okay. It still took 2 more years until 2002 to formalize the response, the global world response. Okay. But I would say basically that from 1997 to 2002, the final response to make the epidemic, starting to control the epidemic, happened and has been exactly what I described to you at the last lecture happening. And this became with this very sort of almost an advertisement slogan from the World Health Organization in 2003. This say, let's begin the 3x5 initiative. Okay? 3x5 initiative. What does that mean? It was like an advertisement campaign, right? Okay, 3x5. That meant in 2002, we have nobody on treatment. Let's have the target to treat 3 million people by 2005. That's what 3x5 meant. Okay. And the guy who set this slogan and this sort of vision of the next years happened to be Jim Kim, okay? He was the head of the HIV department of the World Health Organization, okay? But he is a visionary person, a doctor, he's a visionary person. He's originally from Korea, from South Korea. And you may know his name because now he has a very prestigious international function. He's no longer in the health field. Have you heard of Jim Kim being an important person among the important international institutions at the moment? No? He is the Director General of the World Bank. Exactly. He is the Director General of the World Bank. Okay. Right. Exactly. In the US. Exactly. But before, he was at the World Health Organization, and he was particularly in charge for a few years of the HIV/AIDS response. And he's the one who said, okay, all the politicians have said we should do something. Now I'm going to steer this, and I'm going to launch this initiative that is completely crazy, okay? Because nobody has received treatment in the world. I promise that I will do everything so that in 2 years from now, 3 million of people will receive it, okay? And as I described to you last time, now we are at about almost 10 million people who receive treatment. That's almost incredible, okay? And the target is to go at least to 15 and possibly 20, and even more than that, okay? So all of this has happened over a very, very short period of time, okay? And remember, in 81, we didn't know the disease. In 83, we just learned the virus. Took a few years to develop treatments. Then the politicians sort of decided we should do something. And then the technicians did the job. The job is not finished, but the speed at which this happened is still quite remarkable. Okay, So let me go into the details, although I gave you some of the details on the previous slides, but I will expand them a little bit. So as I said, the report number one, what we call the index case, was this report in the US of these 5 cases of severe pneumonia, so lung infection, in people who were obviously very young, 29 to 36-year-old, who had the sort of the obvious, they were not typical of the U.S. population, but they were certainly typical of a certain population in San Francisco, because they were all men who had sex with men and were living in peculiar situation at that time. But from there, it was rapidly, as I said, developed in a completely different set with men, women, intravenous drug users, etc., heterosexuals, etc. The discovery of the virus in 1983. I give you the name of the Nobel Prize winners. So Professor Luc Montagnier was the head of the lab, okay? And Françoise Barré-Sinoussi was the virologist, the scientist, who basically, looked at the microscope and said one morning, there is a new virus here. Okay. And Luc Montagnier is retired now. Françoise Barré-Sinoussi is extremely active. Okay. She's a sort of an advocacy person, because when you have a Nobel Prize, you can say a lot of things, and people listen to you seriously, okay? And she is active everywhere. I was with her in Vietnam last week, and she's extremely active in the global fight against HIV/AIDS. Okay, let me explain to you a little bit more how the story moved from 1981 to now, just to explain to you the difficulties we face with a global problem. Okay, with the difficulties we face with a global problem. I know many of you are more oriented toward environmental problem, but to me that's not different. In 82, 85, in France and elsewhere, basically all of this was sort of contemplated without a lot of action. Okay, and very sort of as examples of what happened, this is the time where activists appeared on the surface of the problem. Before AIDS, the social society was never extremely responsive. Okay, you never heard about groups of action, against measles, or against cancer, or against hypertension. If people had the disease, it was a sort of individual relation with their doctor. Maybe there was some prevention, global prevention, but they remain relatively quiet. Okay? Here with the non-governmental organization, what I call activists, this is really the first time in health history that people went in the streets to say, this is no longer acceptable. You governments must do something. You must help us, okay? Remember this, because this has happened many times now in the history of health conditions. I think one of the vivid examples in this country is what has happened after Fukushima 2 years ago, and that's not finished, okay? But before AIDS, never happened, okay? Before AIDS, that's never happened. And just to give you a sense, in September 1985, if you were asking medical doctors in France whether they felt AIDS was a problem, almost nobody would say yes, okay, because that was not a problem. And certainly at that time, nobody had understood that, okay, there was a small problem in San Francisco, New York, Los Angeles, Paris, but that the problem was on the African continent. In fact, there were very few reports from the African continent of European scientists going there, observing that basically the patients looked very similar to what they had in their hospitals in France or in the US. But there were patients everywhere. Okay, so the disease was already absolutely everywhere. But when they came back and say, we have a big problem there, nobody cared. Nobody cared. Okay? Okay, going back to business. 83, the discovery of the virus. It took 2 more years, 85, so that the discovery of the virus was translated into a technology advance, which is the discovery of the antibody test. Okay, very important. Very rapid. Again, now it's becoming very common that when the new virus or a new threat is appearing, in almost a few months, molecular biology makes this happening. Okay, in 1985, it was, the first time in medical history where we were so rapidly capable of transforming a sort of a basic science discovery into an application, immediate application. And the screening tests were marketed. Big competition between French and American laboratories because people understood that there were a lot of patents behind that. Okay, but that's the way it was. Okay, 82, 85. Basically, the public health specialists really wonder whether what that was worth looking at all of this very seriously. Okay, because we were talking of 400 cases at the beginning of 82 throughout the world. So maybe this is like now the SARS or one of these mysterious diseases that you see spreading in Asia, but they almost disappear quickly. Okay. The problem with AIDS is that a year later or 2 years later, we were already at 12,000 cases, meaning that the magnitude was not exactly the same. And that's why the problem was considered serious enough so that in 1985, this is the first time a conference was held to review the science and to think about what to do about it. People, to be honest, I was there, didn't feel that that was important to act. But at least they wanted to share information and try to make some sense of what should we do next. But nobody wanted to act immediately, okay? And nobody would invest a penny in things. Whereas at that time, except for blood products, whereas at that time, we knew that heterosexual transmission was happening. We knew that male homosexual transmission was happening. We knew that intravenous drug use was transmitting the disease. And we knew also that the virus was transmitted from the mother to a child. Okay, but no response, observation, counting the deaths and the cases. Basically, that's what it is. The good thing from an epidemiological standpoint, I am an epidemiologist, is that people at that time were able to make a definition. So at least we knew what we were talking about. We knew that in Mongolia or in Central African Republic or in Los Angeles, when people were referring to AIDS, they were using the same definition. So then the statistics become accurate. Okay, that's a big problem in public health. Okay, what are we talking about? If we have a good definition, we can then sort of make good statistics. That's at least the first step. Okay. Okay, now let's go over the second part of the 1980s. Most of you were not born, right? Okay, but many things happened at that time. First of all, we started to screen blood donations. We had this new technology, the antibody test. We could at least easily screen blood donations. Okay? Screen blood donations, it's a public health measure, but it's also a medical measure that people like easily. So that was not so difficult to implement. Okay? There was some debate. In France, for instance, there is what we call the contaminated blood crisis. what happened? We love blood transfusion in France. Don't ask me why, but I know the doctors in the 80s, they were prescribing very easily a blood transfusion. You don't feel well, you have a small surgery, okay, we give you a blood transfusion. No, I'm serious, okay. You're pale, okay, we'll give you a blood transfusion. No, I'm serious, okay. And there was such a high demand on blood products in France that the people in charge of the blood bank business made some very bizarre choices. Like, they decided that to get the proper blood stock supplies, they will go to get blood from voluntary donors in jails. Jails, okay? And if you are in a jail and that you are asked whether you want to give your blood, you are not in a terribly easy position to say no, right? Okay? So you say yes. So people were going to jail, blood specialists, they were taking blood, and this blood was then sent to patients. Okay. The problem is that in jails, you find people who are in jail for all sorts of reasons. Some of them being that you can be an intravenous drug user and you are addict and you have some legal problems. Some of them because you may have entered prostitution or you may be in a very fragile position. You are a vulnerable group, what we call now. And you have therefore many, many reasons to have received the virus, okay, and to harbor the virus, and then to have the virus in your blood that can be transmitted to others, okay? And because these choices were made in my country, we had at least for a year or two a very, very poor management of the blood supply with transmission to hundreds of people, which were absolutely unacceptable. Okay, is there any Chinese citizen here? Not today? Yes, there is. In your country, this has happened as well, much more recently, okay, with multiple injections, small fractions of blood products. So at least in one province of China, this has been an enormous blood crisis, very similar to the blood crisis we experienced in France in the 1980s. So we have not been the only country where this has happened. The good point is that in 1987, the government of France took actions. And to be honest, I don't know why. I don't know why in the sense that it's the Prime Minister of France was Jacques Chirac at that time. Before he became president, he was Prime Minister. He was not particularly open to societal problems. He's more on the right-wing thing than anything else. But he had a very good Minister of Health who understood that the issue was just like this. And this lady, who was a doctor, all of a sudden decided that once we will advertise condoms. Before 1987, in a country like mine, condoms promotion was prohibited. Prohibited. Okay. She also authorized syringes to be sold freely in pharmacy and advertised publicly for intravenous drug users. Before that, if you were doing this, you would go to jail. Okay. Major shift. Okay. She created centers in hospitals to take care of the patients. That was very poor response, but that was much better than before, where basically any clinician was, left alone in his corner to handle the patients. So this is exactly the kind of things that happened in one country at one point in time that start to make a difference. It was a very sort of technical public health approach of a problem, but it was also, as I say, a political approach. Okay? Because the Minister of Health in my country would have never made these decisions if the Prime Minister had not allowed her to do. And I believe in China, when all the problems that I described happened, if there has been a good response, late but good, this is because at the political level, the decision was, yes, this is okay to act. Okay. So we are moving from a very medical problem to a societal problem and to a societal response. That's what I want you to take out of that. Okay, all the rest of the details are completely, are really marginal. The fact that by 1988, we authorized the fact that in France you could go to dedicated places where you could ask for an HIV test without giving your name. Okay, what I call an anonymous counseling and testing center. Okay, that's also a brand new approach to prevention and screening. If you can go somewhere and say, listen, I feel that I am at risk, or I feel that I have taken some risk, and that I want to be tested to know my status, that's a completely new approach. Okay. And we know now, I don't want to have time to go into the details, that this has been the case all over the world. Okay. When you authorize people to know their status, you improve the response against the disease. Okay. The fact that we created research agencies and so forth, that's a sort of a detail. A couple of more elements, sort of more technical, so I won't go too much into the techniques. But we learned at the same time how to monitor this new infection. Okay? We learned that we needed to do something different from the other diseases to just have good statistics. Okay? And one of the things we learned is that we could do sentinel surveillance, what I call unlinked anonymous, which means that we have learned in the 80s that we could go in the population, ask people to give blood for the single purpose of describing the magnitude of a problem. So these people who were tested, for instance, they were not given their result. Okay? If they want their result, they need to go to one of the centers that I just described. But that's the only way to get good quality data, for instance. But that's very technical, so I won't go into this detail. Because I want to move to the next decades, some of you may be born in this decade, right? In the 1990s, right? I don't know. When are you born, most of you? How old are you? 85? Okay. Oh, but the other one look younger, huh? Probably in the 90s. In the 90s, I would say, right? Okay. Okay. Remember, in the 90s, we have been struggling with this for a decade. Okay. We know almost everything from the beginning. Very few countries have done what I have described to you in the French system. And China has done nothing, for instance, but many other countries have done nothing simply because they don't want to hear about it. Okay. And because we don't want to hear about it, and also because we do not have treatment, we do not know how to treat people. Meaning that when you are discovered as HIV positive, it's almost a death sentence. Of course, it's going to take 10 years, but it's a death sentence because we have no treatment to offer to people. And at that time, what is happening is people may wonder, what's going on, and is all of this true? Okay. Is this really true, that we are going to have the virus everywhere, that many people are going to die? Or is there something wrong behind that? Okay? And some scientists even say, I'm not sure of this AIDS business. I'm not sure about the HIV business. Maybe all of this has been, quote, invented. Okay? Can you imagine in scientific, in scientific field that people question scientific advances and scientific discoveries? That's exactly what happened in the 1990s. Very few people, but very influential, came to the surface, wrote a few papers saying, is this true that there is a virus called HIV? Is this true that this is the cause of this world epidemic? Okay. And there was no social network at that time. There was no Facebook. There was no Twitter. But still, the rumor spread. Okay. And at least in one country, and a very important one, South Africa, the president of South Africa, it was later, but the president of South Africa will say, that's an interesting new hypothesis. Maybe this is right, that there is no HIV virus. Okay. It will come later, but this is exactly what happened. But at that time, so people say, okay, maybe this is not true. In this case, this is not a virus business. So maybe we should screen everybody and put all the sick people aside, okay? Maybe we should restrict travel to those who are living with this new disease, okay? And this is the kind of thing that we heard in the 1990s, okay? And that was even more important because the more we were progressing, the more the disease was appearing all over the world in poor countries. So probably the reaction in rich countries, at least for instance in the US, was to say, well, if this is something from the poor countries, we better close our borders, okay? Deal with the patients in our own hospitals and forget about the rest of the world, okay? I'm saying this ironically, okay? But unfortunately, in 1991, for instance, the President of the United States, who was, I believe, Ronald Reagan, yes, passed a law saying if you are HIV positive, you should tell it to the border, and you may be refused to enter the U.S. territory. Okay. This law was passed. Okay. This law was passed. Scientists like myself, like my American colleagues, were absolutely shocked. Okay. Activists were absolutely, it was a disaster. But the law was passed. Okay. We are very far from a medical problem. We are really on a societal problem here, okay? How long has this law been in action in the US? Just a few months, because people were shouting so much that the President of the United States moved back? You think this is what happened? You have any idea when the law that I'm describing, the 1991 law, that allows the US government to reject an HIV-positive person for entering the territory, when do you think this law was cancelled? Yeah, but when do you think, I told you in 1991 this law was passed. Everybody was against that. I mean, it was just a scandal. Scientists, activists, the civil society, but the U.S. representative voted this law. Okay, how long did it take to move back and say, okay, we forget about it, that was a mistake. We realize that this is not a problem to enter the United States with HIV, etc., etc. It took 20 years. 20 years. The president who canceled this law is Barack Obama when he entered presidency. Okay. In between, you had, who did you have? Bill Clinton, very bright, very Democrat, very open. He didn't change the law. Then you had George Bush Jr., the famous, but he has done good things. I'll explain to you in a minute. didn't change the law. Okay? This is only when Barack Obama took power that in his campaign he said, I'm going to change this law. And that's what he did. Okay? And this is extremely important because from 1991 to 2012, there was not a single international conference on HIV/AIDS on the US territory, because all the scientists in the world say, as long as this law will exist, we will not agree with the US government. Okay? So as a scientist, I have been, of course, many, many times in the US in the past 20 years, but we never had a single international conference as long as this law was in action. And this is only in 2012 that the World AIDS Conference went back to the US after 1991 San Francisco. Okay? Interesting from a sort of a societal perspective. You can make disastrous decisions, pass a law, and when a law is passed, everything is frozen. Okay? And that's happened on many other things. Okay, so that was not a very good period. Not a very good period. Okay. And hopefully, 1996 is a complete shift. Okay, a complete shift. Why? Because in July 1996 in Vancouver, you know, the conference was not in the US, but at least it went to Canada. We discovered that with 3 drugs combined, not only we were starting to treat people properly, but they will survive, I would say, almost normally. So we had a treatment, okay? And again, you can say this is just so bad. I mean, the first cases appeared in 1981. The discovery of the treatment, it's 1996. Well, again, in the medical history, this is absolutely unique in terms of, you know, short period of time. But still, millions of people have died in between. And what was spectacular at that time is that these treatments were introduced almost immediately when the science was, you know, proven to be the good result. And basically, I mean, the doctors at that time who were treating patients, their life changed, as did the life of the patients change. Because from basically in 1 year, people who were dying in hospitals, after a few months, they were just feeling almost well. Okay? And, I mean, again, this is something it's hard to imagine how it changed the face of the world. Okay, from this perspective. But a drug, and here a cocktail of drugs, is produced by pharmaceutical companies. Pharmaceutical companies have financial interests. And the interest of the pharmaceutical companies at that time was to produce the drugs at costs that had to be very profitable. Okay? So what they did is that they sold these drugs at that time at incredibly high prices. And they almost organized the sort of the scarcity, do you say scarcity? Yes, of the drug supply, you know. They say, you know, we have invented these drugs, they cost a lot of money, we cannot produce them in high quantities. And then, as you know in economics, when a product is rare, the price goes up, which is good for the market, which is good for the stock, the exchange, the stocks of the pharma, the big pharmas. And in my country, for instance, pharmaceutical companies in 1996, 1997 said, we're not sure how much drug we can supply to your patients. And we had a debate in France. What should we do? How are we going to treat people? Are we going to select our friends? Are we going to select the sickest ones? Etc. And the discussions were particularly important. No solution appeared to be acceptable from a public health and medical perspective. And the advisors, the experts, came back to the Minister of Health and say, we are sorry, but we cannot find a good solution for you. What we will advise is that you randomly select patients who will receive treatment. Because this is unacceptable that Mr. X is treated versus Mr. Y. We are not going to treat intravenous drug users or males who have, men who have sex with men or women versus men. Why don't we take at random patients who can afford treatment? As you can imagine, the societal response was, this is unacceptable. The activists went back to the street, okay, to marshal. And then what happened? The pharmaceutical companies said, okay, we're going to make some efforts. Okay? And we're going to produce more drugs. And we're going to lower slightly the price. Okay? So to understand that, a disease is not only a problem of scientists, a problem of patients, a problem of medical care. There are also private interests into that. And all of these interests have to be put together in a sort of coordinated manner. The very last thing I wanted to say from this period is that at that time there were some major discoveries, and this major discovery was the fact that not only these drugs were given to people living with the virus and treating them, but also it was given to pregnant women. Okay, and for the first time in the history of this disease, almost, as you say now, about 15 years after the beginning of the epidemic, giving them the drugs to a woman who was pregnant prevented the transmission to the baby. Okay. So around 1996, we discovered that with medicines, not only we could treat people, but we could prevent at least some of the transmission. And again, there are not that many examples in health conditions where a same drug can be used. You use drugs to treat people, and you use, for instance, vaccines to prevent. In this case, a drug could prevent the transmission of the virus from one individual to the other, from the pregnant woman to the fetus. Okay, very, very important, and again, immediate application. Okay, swift quickly from 1998 to 2004. Despite all these scientific advances, despite all these movements in the society, the epidemic has continued to spread. Okay. Simply because the response was too slow, too modest. And one part of the world where the most of the expansion has been happening, whereas there was nothing before, is Eastern Europe. Eastern Europe. You are from Eastern Europe, right? And if the epidemic has spread in Eastern Europe at that time, this is simply because there was absolutely no response. Okay, no government, no political response to the epidemic. Okay, you have a good excuse, or one excuse, which was the fall of the Eastern Bloc in 1989, right? 1989, and so there was a big complex situation in Eastern Europe. But still, the fact that there was no global response to the epidemic in this part of the world is still a major problem and remains a problem today. For Africa, I should say particularly that what happened in South Africa is totally unacceptable, because after Nelson Mandela, Okay? What was the name of the president of South Africa right after Nelson Mandela? Remember? No? Thabo Mbeki. Thabo Mbeki appeared to be a good president in many ways. Okay? With AIDS, he was a total disaster. Total disaster. Because some of these very, very bizarre scientists who question the very concept of HIV transmitting the disease and the virus, transmitting the disease, came to him and close enough to him so that they were influential, and that basically Thabo Mbeki was almost convinced, and probably convinced, that HIV was not the cause of the AIDS epidemic that was already devastating South Africa. That basically the AIDS epidemic was a construction of the Western world to defeat South Africa. That at some point in time, his Minister of Health decided that a good response against AIDS was to provide garlic to patients. Garlic. Okay. She had been informed that maybe in garlic there were some good compounds, and that instead of introducing antiretrovirals in South Africa, she would advise that HIV patients take garlic every day. I know you use garlic in Japanese cuisine. I know you use garlic in Chinese cuisine. We do use garlics. We have never proven any way that there is an HIV anti-infective agent in garlic. Okay. So Thabo Mbeki and his Ministry of Health at that time are directly responsible for millions and millions of deaths and people living with HIV because of lack of response, and even, I would say, even worse than that, improper response to the global epidemic. Okay, you understand these kind of things. Okay, very important. But elsewhere, in North America, in Europe, in Australia, people starting to take these drugs, starting to realize that they could live almost normally. Okay, so we have this sort of a divide of the world. In my country, you could start to see people, even if they started late their treatment, to feel much, much better and consider that they could go back to work, have a normal life, consider that they could buy a house, etc., etc. And in the rest of the world, Africa, Asia, except a few countries like Thailand, for instance, Eastern Europe, total chaos and disaster and limited response or no response at all. Okay. And if you understand this, you understand well the figures that I showed you in my first lecture. If you don't understand this, it's very hard to understand how we reach the point where we are today. Okay, I explained to you Abidjan, Durban, the turning tide for treatment in lower income countries. The slogan that Jacques Chirac and Nelson Mandela said is, treatments are in the north, the patients are in the south. This is unacceptable. Okay, unacceptable. Okay. And this became such a big political debate that this went to UNGAS. What is UNGAS September 2011? You need to know this because this is the first time in the world history that there was a UN meeting, UN GAS. It was a UN General Assembly special session. Okay? You know that every year in September in New York at the UN headquarters, all the governments, all the presidents of the world meet for a few days to exchange their views and promise how good the next year will be in the world, conduct. Okay. For the first time in history of the world and in history in the UN, in September 2001, a special session of the UN General Assembly was dedicated to a disease, and health condition, AIDS. Okay. Can you imagine how far we are from what I described to you a few years earlier, when at that time the Director General of the UN plus most of the presidents of the world assembled around of the same table and say, we have a global problem with AIDS, with a disease. This has never happened so far, unlikely to happen at the same level in the future. Okay, so I described to you what happened after that. Barcelona was really the kickoff 2 years later of this. We had very, very strange reports from Haiti, for instance, where you could see basically pictures of Asian, the lady from Haiti, she's not here, huh? Okay. But you could see for the first time pictures of Asian patients with HIV, sick, completely, almost ready to die, put them on treatment, and the next picture was them, almost healthy. This is the first time we saw that from developing countries. These sort of spectacular pictures were very instrumental in pushing everybody to say, we better do something. Okay. And the 3x5 initiative that I just described, at the beginning, people say, we're not quite sure that we can use these drugs in developing countries. They are very expensive, but also this may be just impossible to treat people. So Jim Kim said, okay, 3x5, and even before we think about 3x5, let's do it in 4 countries. Let's prove in 4 countries that this is possible. Okay? This is just, almost history today. Vietnam, you are from Vietnam, right? Yes. One of the countries that was selected to just introduce antiretrovirals in a few hundred patients, just to show that Vietnamese patients could do as better as in France, as good as in Haiti, for instance. Okay. Nobody believed that at that time. Nobody believed that. Or nobody wanted to believe that. Okay, that was a good excuse. They were a good excuse to say, too expensive, okay, too complex, it's not going to work. Maybe we are going to create viral resistance because the patients are not going to take the drugs properly. Okay. There was a very interesting person who talked at that time, almost at that time. He was the Director General of the USAID. Who knows what USAID is? Maybe some of you have a fellowship from USAID. No, I don't know. I don't think so. No. USAID is the equivalent of JICA in this country. U.S. Agency for International Development. JICA, okay. Exactly the same thing. Well, the Director General of USAID in the U.S. said publicly in a meeting, I don't believe that Africans can take antiretroviral drugs because they are not clever enough to take a medicine every day. Okay? Which year? 2004, something like this. Less than 10 years ago. Okay? So when an official person of this level says something like this, the response is slow, to say the least. Okay? I can reassure you he was fired the following day. But still, as an official of the U.S. government, he was capable of saying such a thing in 2004. Okay? So you come from very far away, okay, in all of this. And to finish this story, now the kickoff of the treatment has started. We have millions of people of treatment all over the world. Clearly what is happening now is a difficult story to follow because everything is changing again. And one of the good things that is changing is that we no longer see patients at an advanced stage like we did before. Or we see many less people at an advanced stage of disease because either we are treating them before or if we treat them late, they recover. Okay. So we need to change the sort of the lens with which we look at this, and we change the statistics. But that's, again, too complicated for the purpose of this lecture. What we also need to do is to monitor what we are doing, because, to be honest, again, new breakthrough, and I don't want you to take that everything we do in HIV is remarkable. But in the medical history, in the health history, we have never put millions and millions on people on treatment for life in the world. We have never done that. Okay? So what are the outcomes? What are the outcomes after 1 year of treatment? What is happening after 5 years of treatment? What is happening after 10 years of treatment? We don't know very well. Okay? In fact, we don't know at all, for instance, because the very first patients who received treatment and who have survived, 1996 to today, that's only 17 years. Okay? We know that these people will have to take treatment forever. What will happen after 20, 25 years, I cannot tell. So we need to monitor that very, very closely. What will happen in Africa, the million of people who have started treatment in the past 6 or 7 years, I just don't know. It's very likely that everything will be fine. We may discover new problems. So we need to have good monitoring system, monitoring information system. In Vietnam, for instance, at the moment, because I was there last week, one of the questions is to give access to treatment much more than before to intravenous drug users. Intravenous drug users are the very special, what we call vulnerable population in Vietnam. Okay? There is clear analysis today that we should do much more about that, and the Minister of Health is interested in doing this. If we do it, that's a new story. Okay, so people will have to struggle with attracting people to get tested, attracting people into treatment, follow them, and we need to monitor what is happening, because it's just very unpredictable to a certain extent. Okay, so AIDS has not disappeared. Millions of people still having AIDS. I showed you the figures last time, but many, many less than in the past. So what we have done in many countries, at least in my country, in the US, etc., is we have made an infection mandatory to report. Okay? This maybe, again, you are not doctors, but what doctors report to public health authorities are diseases. Okay? There are mandatory reporting of some diseases. Okay? Here, we are now asking to clinicians, to doctors, to report to the medical authorities people who have a virus. Okay? Whether they are sick or not, it's not a problem anymore. Because we need to have these global statistics on HIV infection. It's very interesting. Again, we are moving from something, it's a little bit like you are in the environmental field, like if soon, for some environmental exposure, doctors were asked to report whether people have a certain level of, I would say, lead in their blood or any pesticide or whatever. Okay, this is the kind of condition that we are interested today, whether people have the virus or not. Very, very new question. We finish because we are almost there. We're almost as today, which was my first lecture. I don't know if you were at the conference that I gave on the Wednesday morning last week, because the topic that I was asked to cover was the end of AIDS. Okay, the end of AIDS, but I put a question mark at the end, because we are not there. We are not there. So I want to make sure that you get this point. We are, I would say, controlling the epidemic in industrialized country. Okay, we are controlling. Okay. Yes, we treat people. Yes, we believe that we can treat people forever. Now, a little bit like we treat hypertension. Okay, almost. Not quite. But we know that people who live with the virus seem to age more rapidly than the general population. So in other words, if you live with the virus from, let's say, the age of 30 and that you are 50, and you are lucky enough to have lived with the treatment for the past 10 years, today it looks like you may resemble somebody who is, let's say, 60, 65, rather than a 50-year-old person. So we will have problem of an aging, accelerated aging population in the future. And as I described to you, in most countries, we are not doing enough about what we call the vulnerable population, the vulnerable groups. Okay. It's pretty obvious for Vietnam. I'm just concentrating on Vietnam because you are here, but also because that's my last trip. That in Vietnam, intravenous drug users, MSM who engage into commercial sex are particularly vulnerable populations, and that there is not enough done at the moment against for them in general. Okay. Okay, having said that, I have the feeling that in most countries where you come from, now we have a sort of we are back to the square one where this is a health problem. Okay, if this is a health problem, people get tested and they get treatment. We know about prevention, that's fine, but it's becoming a little bit like, I would say, cardiovascular diseases. Okay. The societal problem is less and less, obvious. Naomi was telling me it's less and less obvious in Japan, for instance. Okay, where, it's back to it's a health problem among many others. Okay, the societal question around that are less a problem. But in countries in resource-limited settings, that's not true. I mean, it's still a very, very important societal problem that we should deal with. And I believe that in my country, although we have not very many cases, this is still a societal problem because we should have 0 cases. Okay, and I mean all the problems that we have are in vulnerable populations, which is not good. In the last decade, the decade we just finished, we must say that we had success in many countries. Okay. And I've listed 4 of them on 3 different continents here that are really on the forefront of the epidemic because basically their response has been good. And the indicators have been going in the right direction. I can quote Brazil, because Brazil, remember, maybe I didn't tell it, was the first country to introduce antiretroviral drugs and paid for it. Okay. With generic drugs. Rwanda, very small country in the middle of Africa, very, very strong political response, lot of donors, lot of government, the donor country came to bring money, excellent results. And in Asia, we have 2 countries that have done very well, Thailand and Cambodia. Okay. I'm not saying that the other countries have not done well, but these ones have a sort of a global approach that seem to have made the difference. Okay, I will highlight 2 or 3 points, and I'm almost to the end. Yes?
Can you talk a little bit more about Thailand and Cambodia?
Yes, Thailand and Cambodia. Why am I talking about Thailand and Cambodia as good examples? First of all, because the political response in Thailand was very, very, very early. I would say in the early 1990s. At that time, prevention was limited to basically condom promotion and assistance to vulnerable groups. And the government responded very, very nicely at that time. And so the problem of intravenous drug users, of commercial sex workers, was openly, organized and was discussed, and actions were made. Okay, that's one thing. And since then, all the scientific breakthroughs have been rapidly translated into action by basically the Ministry of Health and the public health response in this country. So that's pretty obvious. Cambodia, different, because Cambodia, because of the post-war situation, the immediate response was not good at all. And the epidemic started to spread very rapidly in Cambodia, contrary to Thailand, where it was always under control, almost always under control. But in Cambodia, because the Cambodian government was very open to collaboration with international collaboration, a lot of resources fled into Cambodia. They were grossly well used, and the response has been coherent. And the indicators in Cambodia have gone rapidly in the right direction. So that's different. Yes.
Because the two countries are neighbors, but they're very, very different countries.
Absolutely.
So the Thailand response, would you say, was more of a domestic response?
In the
Cambodia?
1990s.
Yeah.
In the 1990s, already the Thais started to organize their response.
Well, it was one man in particular, the Australian, right, who did condom from it.
But, they were responsive to introducing the drugs at the time, like Brazil, where nobody wanted to use them. Okay. They were responsive to many things.
Okay, but the Cambodia was more of an international...
Yes, and it was 10 years later. It was 10 years later. Cambodia had to control an epidemic that had already emerged, whereas in Thailand, it slightly emerged and then was controlled before going down. Okay. No, the few items I wanted to mention. PEPFAR. What is PEPFAR? Oops, I'm sorry. PEPFAR is the response of the US government to the AIDS pandemic. Basically, before PEPFAR, the US government was spending, I would say, millions of dollars, or, I would say, several hundred millions of dollars per year in the global AIDS response. Okay? It was nice, but that was almost an amusement, I would say. Okay? A president of the United States was advised that AIDS could be a global threat. And one of the arguments that was given by his advisors to this president was that AIDS could create a military threat. It could create a security threat at the surface of the globe and a security threat for the US. So a president of the United States was particularly sensitive to this issue, and this president, amazingly enough, was George Bush Jr. Okay. We could say that he was right-wing, right? Okay. That in this period of the early 2000s, he made not very interesting things. War in Iraq, for instance, etc. Okay? Well, at the same time, he decided to move the US support to the global AIDS control to hundreds of millions to billions. That's the presidential emergency plan for AIDS relief. Presidential emergency plan for AIDS relief. And this president, who did so poor things on the political side, did this amazing thing of putting a lot of the US money into the global aid assistance. And this is because of George Bush PEPFAR program that antiretroviral drugs were purchased for the first time at levels that we are now reaching millions and millions of individuals. Okay. I must confess that I'm not a George Bush fan, but this is certainly a very good thing he did. And that since he left power, his successors have not changed anything. The Senate has not made any change backwards to this. Okay, so this is George Bush's legacy to the AIDS fight. That's what it is. Very last thing I wanted to mention at the bottom of the slide is the role of philanthropy. Okay, the role of philanthropy. This is the first time again in health history where philanthropy has reached this level in influencing the response to an epidemic. Okay? And philanthropy, yes, here can be almost reduced to a couple, Bill and Melinda Gates, because they have been unique in this. Okay? They have not given money to help, I would say, treating people, because they don't believe that's a good use of their money. Okay? But what they have done is they have supported most of the biomedical research. They have supported most of the biomedical research that is leading to today's interventions that we are using in the field of HIV/AIDS. Okay, that's amazing. We know in the past the Rockefeller Foundation has been instrumental. Okay, there are not too many examples, Naomi. Too many other examples, but clearly with the Gates, Bill and Melinda, we have an incredible example of people who have invested money into research that is applicable to the translation into new areas of application for prevention and control. They have done the same for immunization. They have not only done this for HIV, but we have to acknowledge that they have been extremely important for HIV research. Okay, I want to close because I have 2 slides to close. You know, it has been like a honeymoon since 2003. You know, George Bush Jr. has been excellent. We have a lot of money. We treat millions of people. And as I showed you last time, we see many indicators going in the right direction. And we have a few countries that are doing even better, the one that I described. But you have lived in a world over the past 3 to 4 years that have experienced such an economic crisis that this has an impact. Okay. And the impact is that today the likelihood that the funding is continue to increase is very, very uncertain. Okay. It looks like we are almost at a plateau in terms of international investments in the fight against AIDS. And is this an excuse or is it the truth? I cannot really say, but the economic crisis is certainly a major contributor to this situation. Okay. So we have to admit that. The good news, though, in relation to the economic crisis, is that many of the lower income countries, so-called poor income countries, are becoming richer. And now they can afford to pay for their AIDS response. I'm thinking of China, for instance. China, 5 years ago, was receiving a lot of money from foreign assistance to the fight against AIDS. Now China is becoming rich, or rich enough to pay for their own AIDS response, like Brazil was capable of doing 10 years ago. Thailand, exactly. Vietnam is probably close to this direction, although it still needs a lot of support. So there are good things. Maybe France, Japan, US will not continue to increase what they give, but other resources, national resources, can be used. I don't have time to tell you, but there's been a lot of recent scientific progress. The scientific progress that are listed here, some of them are just still scientific advances and that's it. Some of them are more advanced, are more, translated into action. I don't have time to go into the details, but I can tell you that it's moving rapidly. So maybe in the next year or two, you will see major differences in this area. And finally, the question is whether we can absorb all these changes as we are moving along, because we want to treat more and more people, we want to be more and more doing preventive things. We don't have a lot of resources, but still countries can provide them. The thing is that, is this feasible? Okay? Is this feasible, for instance, in a country like South Africa to treat twice as many people as they treat today? Okay. Just, is this feasible because do they have enough doctors? Do they have enough nurses? Okay. In Vietnam, that's going to be feasible. Okay. But in the countries that are really hit, it's just a matter of health organization. How do you do that? Okay. So we have learned things like task shifting. Task shifting meaning, for instance, that we don't necessarily need to have a doctor to give antiretroviral drugs. Okay? About 3 or 4 years ago, you would have said that. I would have come here to talk to you here. I would have been almost crazy. Now we have the demonstration that this is feasible, for instance. Okay? So there are a couple of things like this that are uncertain. And again, the national and international commitment, that's what I said. Barack Obama is not convincing to have the Senate giving it more money than it gives at the moment. But I believe that China can give more money to pay for their own global AIDS response, etc., etc. So all of this is changing. Okay. So the problem is that I don't see exactly how long this is going to take. Okay. And that's my problem. Because Naomi will go soon to retire. I will go to retire before this epidemic is over. Okay. And you may live in a world that still needs the same level of response that I just described to you now, I would say for 25 years. Okay. Don't expect that this problem will be over before 25 years, which is your entire generation. Don't laugh. This is serious. No, I mean, you understand what I mean. Okay? The only exception that could make a difference is that if a vaccine comes through. Okay? But I want to be clear today, there is not such a discovery on the horizon. But you know, in scientific medical discoveries, it can come like this. So we have been struggling with the vaccine for 15 years. 2 years ago, there was a small, good result, but nothing serious. Maybe tomorrow, there will be a discovery. If this discovery happens, maybe it will be shorter than 25 years. But if it's not, believe me, you will be probably struggling with this as a societal problem for the next 25 years. Okay? So the end of AIDS, I have said probably not. But in scientific journals, you can see this kind of question mark now, which is a bit bizarre. You can see this in broad magazines that you may read. That was last year. Okay, so people start to say, okay, we're almost there. We should move to something else. Okay, you have this amazing social network thing that I found a few months ago, and I even found this, which is, do you vote? Do you agree that we should go to the end of it? I mean, so people are really very full of hope, but I want to finish by saying that these hopes are possible, but they are possible on a 25-year horizon, not an immediate one. Okay? I think I'll stop here because it's enough for today. Thank you. Any question that you want me to ask? No? Okay.
Okay.
Yes.
Thanks for your very interesting and about so many history like HIV, AIDS, and I just want to clarify one question because before this I heard this lecture. Someone told me that the AIDS, like this kind of disease, is come from like the blood and like this kind of some roots. But also like this kind of blood transfunction is from people to people.
Yes.
And another way is from like this kind of AIDS come from the insects.
Yes.
Or like a malaria.
Malaria?
Malaria is like from
okay.
this kind of thing.
Okay, so are there other routes of transmission that I just described, which is sexual, blood, and mother to child? And basically what you're asking also is what is the origin of all of this? How did it start? Okay.
Come the transfer route.
Yes, exactly. Okay. From the very beginning, these questions were asked. Okay. It has never been proven any other mode of transmission than what I described. There is no insect vector of HIV. There is no reservoir of HIV outside of human beings. So all of this was known or supposed in 1982, 1983. And since then, no other discovery. But the only thing that has been discovered, and that is interesting, but from a sort of a scientific perspective, is that the virus comes certainly from animal virus, probably in monkeys, that at some point in time, probably in the 50s or even possibly before, we don't know, were transmitted and evolved from these monkeys in central part of Africa to human beings, and then became ultimately the HIV virus. This is exactly what has happened, and we have good molecular biology proofs. But once we know this, that doesn't change anything to the epidemic that we described. But the origin of the virus, yes, it's known. It's an African virus which was in monkeys a long time ago, silent, that probably was transmitted to humans and remained silent for a long time before it became the virus that we know today. Okay? Another question? Yes? Yeah, no, nothing is irrelevant in a global health
Can
lecture.
you maybe give an approximate price per person for treatment?
Yes, of course. When the treatments were, evaluated for the first time and the conclusions were good in 1996, the price of a triple cocktail of drugs was in the range of 10 to 20,000 US dollar per year, something like this, 10 to 20,000 dollar per year in 1996, something like this, and possibly even more. At the moment, the 9 million people we treat in the world, as you say, 95% of them are in resource-limited settings. We treat them for less than $400 per year. Okay, so it's something in the range of $50 or $40 per month. Okay, but yes, yeah, yeah. Yes. Yeah, the thing is that there are two things that you need to understand. First of all, there's been now about 3 or 4 generations of drugs, successive generation of drugs. The first generation of drugs is no longer in use because it has been proven to be toxic. Second and more important, third generation have been proven to be more efficacious, less toxic, and produced by generic companies. Okay? So the price, and in huge quantities because of the demand. So the price have been going down. Now we have a 4th and possibly 5th generation of drugs that have just over the past year been released on the market in Europe, US, Canada, Australia, are still very high prices. And they are possibly very, very attractive for the future. My bet is that there will be 2 prices. The price for rich countries and the price for other countries. And that we are not going to wait 10 years until the difference in cost is reached. So they will remain very expensive in the US and in Europe, and they will drop for the rest of the world because we are not going to wait, until 10 years ago that the patent is almost finished to have the negotiation and lower the price, etc., etc. Because the trade issues have changed over the past 15 years, and because of AIDS. Health products, through the Doha trade agreements, can be exceptions. Public health emergencies can be exceptions. And this was not in existence before. So I bet is that we're going to see major changes in this, rapid changes that we did not see in the past. But I give you an idea of the price range. Yeah. Final question?
I'm just wondering how fast will an infected person know that he is infected?
How fast will he know?
Yeah, like symptoms, he or she, the person, first symptoms.
Okay. In 95% of the cases, what we call acute infection, which is exactly what you described, which is the symptoms that may happen in the weeks after contamination. In 95% or 97% of the cases, this is silent. This is invisible. Only a few individuals have sore throat, flu-like symptoms, etc., in the few weeks after contamination. After that, if you remain asymptomatic like this, it's going to take at least on average 10 years before the symptoms arrive. And that's why policy has totally changed over time, that now we want to promote testing everywhere, all the time, as soon as possible, and as many occasions as possible. Because the intent is to depict and inform people as soon as possible after they are positive, and possibly treat them quickly after that. So, that's the answer? Yes? Okay.
After window period for
Yeah.
several weeks,
Yeah.
so you should wait
Yeah. Yeah.
after dangerous sex or something.
Yeah.
After that, you can know, even under asymptomatic state. Okay?
Yeah.
During 10 years asymptomatic, but
Yeah.
by testing,
Yeah, you can know. You can know whether you are positive. And what was, if I had given the same lecture 10 years ago, I would have, or 5 years ago, I would have said, go to the doctor to be tested, right? Now what I've just briefly described that I could expand is that there are many opportunities to be tested everywhere. You have anonymous testing. You have now, over the past 2 to 3 years, rapid tests. You can go to a clinic and get a test and get an immediate response. You have almost on the market self-tests. So very soon people will be able to buy tests at the pharmacy and like a pregnancy test. Okay? So all these opportunities of testing are completely changing the face of the epidemic and the response of individuals and the societal response. But it's just now in the process. In Africa, in many African countries, what they do now, because the size of the epidemic, is to do home-based testing. You know, I'm doing a program in South Africa where in a part of South Africa where almost 20% of the people are believed to be living with the virus. 20%, 1 out of 5. So you see, in this row, there will be 3 people living with the virus. Okay? What we do is we are promoting home-based testing by lay counselors, people who are not medical at all. But they want to go home and they say, listen, you know what AIDS is, you know what HIV is, we can offer you solutions, get tested. You want to be tested? We can test you now. Okay? 5 years ago, you would not have done these kind of things. And contrary to Thabo Mbeki, who denied AIDS, okay, President Zuma, has said openly over the past 2 years, I want all my people tested in this country. He said that on TV. He said that on radio. So when at this level you have this kind of message, you know, the general atmosphere is changing. Okay?
Weakness of Japan is weakness of HIV testing.
Yes, in my country that's the same.
Why Japan is increasing HIV cases,
Yes.
even though it's a very small number, but increasing.
Yeah.
Japan is the only country where AIDS is increasing because of weakness of HIV testing.
But you know, in France, we have recently promoted universal HIV testing, but we are not doing it. Okay. But the official policy is testing should be offered to anybody. Nobody should be denied testing. Okay, but it's slow.
In France?
Yes.
Yeah.
Yes. I mean, the policy that was released about 2 weeks ago. Everybody should be offered testing anytime, and all of those who are found positive should be treated immediately. And we have been congratulated by the Americans, by the Canadians, to have made these decisions over the past 2 weeks. I cannot tell you that this is happening today. It's going to take a lot of time. And certainly we want to have this promoted in gay bars, in nightclubs, in places where intravenous drug users use, but in a more general sense, because like in France, for instance, there are many people traveling and living in Africa who come to France. So there is a mix of population. So we need to offer this testing approach to everybody at this stage. And I can tell you that even the economics of it has been studied, and that it is proven to be medically, economically, what we call cost-effective. Okay, it's going to cost to test everybody. Okay, but the rationale of treating early and avoiding health expenses, etc., is better than the cost of all of this. But that's not done yet. Okay, thank you very much, and have a good.
Yeah. Thank you so much, Francois, for very updated and impressive talk, reflecting our past history of HIV. Thank you so much again, and come again, maybe in future also. And please tell us the title of a report or something. Homework.